Hi, my name is Patrick and I'm a Pulmonary and Critical Care Fellow, and this video is on CPET normal values and interpretation. So when you initially are interpreting a CPET, the first three steps should be looking at the VO2 peak to see if it is 85% or more of the predicted. The second step should be looking at the anaerobic threshold to see if it is more than 40% of the predicted VO2. And then the third step should be looking at the breathing reserve to see if it is more than 30%. And the reason that these are the first three steps is that it helps you immediately categorize this test as normal, abnormal, and potentially cardiac or pulmonary in disease processes. So building on those first three steps, we can add the fourth and fifth step of looking for a predominant system limitation and checking to see if the findings are compatible with the patient's history and previous testing, because it's important to remember that the data that we're gathering during a CPET should be interpreted in the context of this patient, and that CPETs unfortunately don't always neatly fit into one specific category. Algorithms for CPET interpretation exist and can be very helpful. This is one of Wasserman's flowcharts, of which he had several. These flowcharts can become complicated and they should not override the patient's clinical context. This is a collection of normal values that our lab uses, keeping in mind that labs around the world will all have slightly different reference ranges, but the principles remain the same. So again, you look initially at the VO2 peak, the anaerobic threshold, and the breathing reserve. Our lab defines a normal breathing reserve as somewhere between 30 and 50%. After this, you can look at the pulmonary variables, so the respiratory rate, which we say is less than 55 breaths per minute. Then you can look at the tidal volume over the inspiratory capacity, which is typically around 70%. And then you can look at the measures of ventilatory efficiency, which we use less than 30 and less than 34 as our numbers, but there are tables for age, height, weight, and sex available. Then you can look at the cardiac variables like heart rate, systolic blood pressure response to exercise, the O2 pulse of course, and the VO2 to work rate slope, before finally looking at measures of oxygenation like the SpO2, and it is acceptable to desaturate up to 4% from your resting SpO2, but a desaturation of 5% or more is clinically significant. I have broadly categorized conditions as cardiac or pulmonary, so we will start with the cardiac disorders first. Remembering the adaptations that our bodies make during exercise and endurance training, think of deconditioning as the opposite. In deconditioning, it is almost like a mild disease form. You can have a reduced stroke volume, and thus you have to rely on your heart rate climbing very quickly to compensate during exercise, similar to a cardiac myopathy. You also have impaired peripheral muscular contraction and O2 extraction because your mitochondrial function and density is reduced, and this leads to early fatigue and poor O2 delivery. So because of this, you will have a normal or likely reduced VO2 peak, but you should have a normal anaerobic threshold and breathing reserve. Your respiratory variables should be normal and you shouldn't have any signs of ventilatory inefficiency, and your heart rate response should be normal, as should your blood pressure and O2 pulse. However, it could also be reduced, and your VO2 work rate slope could also be reduced, but you should definitely not desaturate. All patients with heart failure, be it ischemic or idiopathic or preserved or reduced LV function, have difficulty in transporting oxygen to the muscle during exercise. Because of this, they have a reduced VO2 peak and a reduced anaerobic threshold, but they should have a normal breathing reserve, a normal respiratory rate, and a normal tidal volume to inspiratory capacity. Because of their reduced cardiac output, they have reduced right-sided pressures and reduced recruitment of capillaries in the lungs. So they have a high VQ mismatch with lots of dead space, and because of that, they have evidence of ventilatory inefficiency in that they'll have an increased minute ventilation to VCO2 slope and increased ventilatory equivalence for VCO2. Their heart rate will likely be reduced either because of chronotropic incompetence because of beta blockers or other medications they're on, or because they've stopped the test a little bit early because of severe symptoms of dyspnea and fatigue. Their blood pressure response could go either way, but their O2 pulse should be reduced, and their VO2 work rate slope will also be reduced. In contrast to patients with acute myocardial ischemia during a test, it's a gradual decrease in the VO2 work rate slope as opposed to a sudden decrease. And their SpO2 should be in the normal range. It is possible for them to desaturate, but it is less common. Now, looking at patients with coronary artery disease, their VO2 peak will be reduced, their anaerobic threshold will be reduced, but their breathing reserve as well as their other pulmonary variables should be normal, including their variables for ventilatory efficiency. Their heart rate is sometimes increased, and they typically might have EKG changes concerning for ischemia. Their blood pressure response is typically normal or slightly reduced, and their O2 pulse is typically reduced with an early plateau, and their VO2 work rate slope is classically normal before decreasing, and they don't typically desaturate. And if we look here on the side, we can see their heart rate, for example. So if this is the predicted trajectory of their heart rate, and this is the predicted heart rate max, you can see that they have this increase, this sudden increase, and that is to compensate for a decreased stroke volume. And that decreased stroke volume is because all of a sudden there's myocardial ischemia and poor perfusion and dyskinesis. And here at the bottom we can see that the O2 pulse all of a sudden plateaus and sometimes may even dip, and again that represents the ischemic changes to the myocardium. Now looking further at patients with CAD and their VO2 work rate slope. So remembering in heart failure it's gradually decreased, whereas in CAD it's abruptly decreased because the myocardial ischemia causes failure to generate enough ATP, and then the stroke volume suffers, and then there's dyskinesis, and then the VO2 work rate starts to decrease all of a sudden. And this can happen before chest pain develops. So here on the top right we have a normal graph of VO2 to work, and down here we see VO2 in white circles, and then all of a sudden it just drops, and you can see that here. Now looking at chronotropic incompetence, which can be caused by a number of different things. It can be iatrogenic because of beta blockers or calcium channel blockers. That's why it's very important to check their medications. Or it can be because of sinus node dysfunction or autonomic failure. And how you distinguish this from a submaximal effort is you can look for signs of effort like the respiratory exchange ratio, which will typically be more than 1.1 unless it's a submaximal effort. These patients will have a low VO2 peak and they'll have a low anaerobic threshold, but they'll have an increased breathing reserve. And the reason for that is they typically stop very early on in the test, and that is because of leg fatigue and just general sense of heaviness, not because they have reached their exercise limit. Their respiratory rate is normal, their tidal volume to inspiratory capacity is normal, but their markers of ventilatory inefficiency are elevated, and that is because of their poor cardiac output, which leads to poor perfusion of the lungs and increased dead space. Their heart rate is typically low because of the medications or the autonomic dysfunction, of course. It's one of the defining features. Their systolic blood pressure response is either normal or reduced depending on the medications or the cause. Their O2 pulse, interestingly, can be normal or increased, and the reason for that is that because your cardiac output is your heart rate times your stroke volume, if your heart rate is unable to increase, then the only possible way for you to increase your cardiac output is by compensating for your low heart rate by increasing your stroke volume in addition to normal. Their VO2 work rate slope is typically reduced and shows an early plateau, and they don't typically desaturate. And here on the right we can see the predicted heart rate trajectory for VO2, and they are down here. So if this is where they end up, this is where they should end up, and this is obviously abnormal. Now in a patient with peripheral arterial disease, their maximum VO2 and anaerobic thresholds are reduced because their peripheral arterial disease has reduced the internal diameter of their conducting arteries to the limbs, and this prevents the increase in blood flow needed to meet the increased metabolic demand of exercise. So because of that, they'll have a reduced VO2 peak, and they may have either a reduced anaerobic threshold, or it may be hard to see if they've even reached their anaerobic threshold because often they'll stop because of severe claudication. Their breathing reserve as well as their other pulmonary variables will all be normal. Their heart rate will be reduced, typically because they've stopped the test early because of severe claudication. Their blood pressure response will be very elevated, if you remember Ohm's law, because they're unable to adequately reduce their systemic vascular resistance. They have this excessive rise. They'll have a normal O2 pulse peak, and their VO2 work rate slope will typically be somewhat reduced, and they don't typically desaturate. Now looking at the pulmonary disorders. Now looking at patients with obstructive lung disease, these patients will have a low VO2 peak, and again they may have either a reduced anaerobic threshold or they'll have no anaerobic threshold visible because they've stopped because of exertional dyspnea and severe symptoms. Importantly, they'll have a reduced breathing reserve. They'll have a normal respiratory rate, which helps identify them and separate them from people with restrictive lung disease. Their tidal volume to inspiratory capacity will be increased, and this is because of dynamic hyperinflation. They'll have evidence of ventilatory inefficiency because of a high VQ mismatch. Their heart rates will be low because they've typically ended the exam a little early. Their blood pressure response, O2 pulse, and VO2 work rate slopes are typically normal, and it is possible for them to desaturate. And compounding their ventilatory disease, they often avoid exercise and because of that are somewhat deconditioned. Now looking at patients with restrictive lung disease, they'll have a low VO2 peak. Again, their anaerobic threshold will be reduced or maybe not evident because they've stopped because of symptoms. Again, they'll have a reduced breathing reserve. They'll have, importantly, a very elevated respiratory rate, compensating, and they'll also have an increased tidal volume to inspiratory capacity, and the reason for this is that they have a low inspiratory capacity to begin with. They'll have evidence of ventilatory inefficiency. They'll have a low heart rate because typically they'll have stopped early because of severe symptoms. Their blood pressure response and their O2 pulse will be normal, and interestingly, they tend to have a reduced VO2 to work rate slope, and they do typically desaturate. Lastly, we'll look at a patient with pulmonary vascular disease. These patients will have reduced VO2 peak, reduced anaerobic threshold. They'll have a normal breathing reserve. Their respiratory rate will be normal. Their tidal volume to inspiratory capacity will be normal, but they will definitely have evidence of dead space and ventilatory inefficiency. Their heart rates are normal. Their blood pressure responses are normal. They'll have a reduced O2 pulse, and they'll have a decreased VO2 to work rate slope, and they typically desaturate. When you see desaturation, you should always think of pulmonary vascular disease or possibly restrictive lung disease.